unless I'm missing someone. Okay, I'm inviting Renee now, so I believe that gives us a quorum. So Dale, I will go ahead and turn it over to you.
Okay, thank you. You say we do have a quorum?
I have you, I have Krista, Linda, and Renee. And I
Okay.
would like to remind the members, in order to comply with Kentucky open meeting laws, when you are voting, you do need to have your camera on.
Got it. That's correct. Thank you. Well, good morning, everyone. Thank you for being here this morning. The first thing on the agenda is to review the minutes from the November 14th meeting. I've already reviewed them, and if the rest of the members would take a vote on accepting them or amending them.
A motion to approve, Dale.
Any yeas?
Yes. I also agree.
Okay, thank you.
I
We accept the minutes. I approve as well. The first thing on old business is to follow up from the Department of Medicaid Services. What are the department's study findings on increasing the OT, PT, and speech fee schedule? This has been on the agenda for quite some time, and we're just asking for a follow-up. If anybody with EMS is on here that can address that.
I believe Justin Derringer would be the one to address that, and I don't see him on yet. So if you want to move on to the second item, maybe we can circle back around.
Okay, thank you. The second thing on the old business is the follow-up with the process of getting a retro PA from traditional Medicaid when a member applies for disability and is assigned from an MCO back to traditional Medicaid. So is there anyone on here from DMS that could address this? How is that process going to make this smoother to?
Hi, this is Kelly Kitchen. For prior authorizations, anytime that there is a someone is in an MCO and they are then assigned to traditional Medicaid, that provider has 1 year from the date that they were assigned as traditional Medicaid to get a prior authorization.
So is that process going any smoother to go retro back and pick up the traditional Medicaid auth?
Sorry, Dale. I think I was driving here and I had to pull over. So I think that the issue is that it's just constantly they're still retroing back, and so it's taking us. It's just more work on our end that we were asking if the state could just take it so we weren't the middleman here. That's what we're asking. Were you able to hear me?
Yeah, I am. Thank you. Yeah, at our clinic, we haven't had an incident of having to get a retro auth because of this situation. So I can't really address it from our clinic perspective, but I'm hearing from other clinics that this is a lengthy process, and
Yeah, it's the eligibility. It's, yeah. Their the eligibility.
I understand the DMS was working on a process to make it smoother and faster to get these authorizations.
Yes, this is Jennifer with APT with Renee. I'm the revenue cycle director.
Hi, Jennifer.
So two things on that. I believe on the last meeting, somebody from DMS said that they would actually not require us to get the separate auth. If we already had one from the MCO, we could turn in the information from the other auth we had and it would be approved. But expanding on that, the biggest issue really isn't the auth process. It is going back and even trying to get these claims paid all together. We are not aware that these retro changes even happen until an MCO recoups money from us. Oftentimes that is only leaving us a 1 or 2 month window to even try to get these paid. In addition, a lot of the time from what I'm experiencing, we've had like over $80,000 in retro eligibility recoupments happen over the last several months. So it is hitting us very hard to try to keep up with these, number one. Number two, if I only have 2 months and a lot of these are already over 1 year old, the special process we have to go through has been very unclear on how to get these claims past that timely filing edit, because we're already past a year. I cannot just submit these like normal and get paid. It is extremely burdensome and is just a process we cannot keep up with. And our window of time is extremely small by the time we are even made aware that this happened.
Yeah, that could be a serious problem as far as revenue, especially with smaller practices. So what can DMS do to remedy this?
I think we need to take this back to Justin and see if there's anything that we can do to help assist the providers with this.
I think Justin had said on the last meeting that they were looking at the possibility of just removing the providers from that financial process when these happen altogether. They just at that time had just not worked out what they would need to do to update the system and the process to make that happen. But I think overall that is what we would like to see happen, is see that financial exchange occur between the state and the MCOs and leave the providers out of it.
That was my understanding also, that they would recognize the authorization that was already received and they would just go ahead and authorize.
And so are they, is DMS like paying retro back paying these recoupments right away, or?
Once we can obtain an auth, if as long as the claim is less than a year old, then yes, we can get that paid really quickly. The troublesome part becomes when the claim is over a year old already. The process to go through on that is a lot more cumbersome and there's a lot more paperwork involved.
Well, hopefully whenever Justin gets on, maybe he can give us some data on that and how we can make that process better. So we will, when Justin gets on, we'll go back to number 1 and 2 in old business. And so the next thing on old business is the credentialing process. Assistant Director Jeremy Armstrong talked to Cresta Wilson, I think it was this last month, about the credentialing timeline, and it's 30 days for the MCOs, and then 10 days to upload the new therapist in the system for processing claims. Is Jeremy on this call this morning?
Good morning, this is Jeremy. Yes, I'm here.
Good morning, Jeremy. Could you address this?
Yes, sir, I did. We shared communications across all MCO plans of the expectation. Plus, we made a contract amendment that went into effect on 1/1 of 24 just to ensure alignment to regulation and expected turnaround times for these MCOs to complete credentialing for a provider within 30 days, contract with the provider in 30 days, and then upload the provider's fee schedules appropriately within 10 days.
So that's 70 days possible from start to finish. Is that correct?
That is correct.
Just so that there's not confusion there. It's a little confusing sometimes, or at least on my end, I was confused about 30, 60, 90. Everybody was saying something different. So, so if that makes sense, it's 30, 30, 10, easier way to remember. Yeah. Thank you for the clarification, Jeremy.
Absolutely.
So 30 for Medicaid and then 30 for the MCO and 10 to upload, right?
No. So credentialing still has 30 days with the MCOs, and then contracting has 30 days.
Oh, okay. Got it.
Both are 30 days to allow the MCOs and the providers to engage to ensure that the MCOs receive a clean application for credentialing. And then for the contracting perspective, they have 30 days to have an executed signed agreement between the provider and the MCO plans. And then once that signed agreement is in place, those MCOs have 10 days to load those provider specific fee schedules and contracted rates into their system.
Got it. Yeah, that makes sense now.
Dale, this is Pam. Can I ask a question?
Sure.
Hey, Jeremy, what is the process for non-compliance? Because I think all of us have experienced non-compliance, even with the past understanding of 90 days, that this is now less time. I can't imagine that unless processes are changed by the MCOs, there's some that will not be able to meet this timeline under current conditions unless they change things. So my question is, what then do we do? What is the process to hold them accountable for that?
Well, one of the first steps that a provider should take when a policy or disagreement with a policy or non-compliance issue to state contract and regulations, one of the first steps a provider can take is filing that grievance through the MCO plans. Grievance will allow the MCOs an opportunity to correct and rectify with that provider directly. But then for anything non-compliance issues that still fall into that bucket, come into the state to report through the provider MCO inquiry box of that non-compliance issues would be the expectation to follow for the providers, for the state to take action of non-compliance against the managed care organizations. Now I can put that email box in the chat so that way everyone would be able to have access to it. But the department, I can say, is continuously monitoring our MCO plans on their credentialing, contracting, and loading providers. So if you do receive something outside, if the MCOs are not processing outside those timelines that's been described today, please be sure to bring those to the state's attention.
All right. Thank you, Jeremy. The next item on old business is to request the following CPT codes to be added to the PT speech OT fee schedule. And those were added to the fee schedule. And they have been approved. And I'm just there was a question from a TAC member if, will they be loaded into the 2024 fee schedule?
Yes, we have a request submitted, to have them added in the system. Of course, you know, that takes a little bit of time for them to get the system updated, and we will be adding them to the fee schedule.
Thank you, Kelly.
You're welcome.
Dale, I have a question. It's Pam.
Okay,
One of the questions is, what is the compliance expectation for the MCOs to get those codes added to the prior auth process? So each MCO has a different prior auth process and a different way to submit. Currently on our fee schedule, there are some CPT codes that are approved that are not able to be obtained through like the codes are not even a choice for the PA, yet there's no medical policy stating otherwise from that MCO. So what is the DMS's compliance to hold the MCO accountable that all the codes on the fee schedule are available for prior auth and use? In regards to these new codes and current codes.
anyone from DMS that can answer that?
So this is Jeremy. So when we update or add a new code to our fee schedules, we send a notification to all of our MCL plans with the expectation of in 30 days, they'll have those codes added to their fee schedules for the impacted providers. And then any of those codes that are expected to have that prior authorization utilization should be added within that 30 days as well.
And then what is the step, Jeremy, for if we're unable to obtain a prior auth for certain CPT codes that are on the fee schedule? What is the process to get that corrected?
So one of the first steps is to engage with those specific MCO plans. However, if you're getting any type of pushback or delays beyond that 30 days, then that's when you can come to the state, to the department, to bring that issue and concern. So that way we can rectify that. Because that would be the expectation for the MCOs to follow.
Okay, does that answer your question, Pam?
It does. I'll go back and confirm. I'm fairly certain we have already dealt with the MCO, but nothing's changed. But I will double check that before submitting that to Dale or submitting that to you, Jeremy, that there's non-compliance in that area.
Thank you, Pam.
Okay, the next thing on old business is the Medicaid complaint process. I understand it's been changed somewhat and it's a lot more lengthy process. Can anybody from DMS comment on that?
So this is Jeremy again with DMS.
Mhm.
And so what has changed is in the Medicaid complaint process is the reviewing of the provider complaints that are received. And identifying what we've identified within those provider complaints is a behavior of providers attending to come to the state first to report the issues or concerns and not specifically following the MCO's internal disputes and appeals process. And so that was the change from the Medicaid complaint process, that if the Medicaid liaisons for the MCOs who receive and review the provider complaint indicate or see that the provider hasn't followed those internal dispute processes and they're within their timeliness to be able to take those actions, then that is the responses back that the providers are receiving is to follow that route first. And that's truly just to afford the MCOs the ability within their individual contracts that they have with providers for the providers to be following those internal disputes and appeals process. So that's really the change as far as, we have updated a little bit of our form itself, which I'm happy to share with the Therapy Tech attendees as well. But really the change is just to identify the providers who have not followed the internal dispute and appeal processes within those timelines. And if they are able to follow those internal appeal and dispute processes, then that is the department's request back to those providers who have submitted, is to first to try to attempt to go that route. And then once the decision or determination is received by the MCO plan, then you can take those next additional steps for either an external independent third-party review or potentially coming to the state to file a provider complaint. Just understand that coming to the state first to file a provider complaint, it may not afford the provider the external independent third-party review if you have not already taken that action within that 60 days of that adverse benefit determination from the MCO.
Yeah, that makes sense. So they have the MCO has 60 days to resolve the complaint. Is that what you're saying?
So it's more or less the MCO appeal and disputes. A provider has 60 days to file a dispute or an appeal. And then you have from that adverse benefit determination, you have an additional 60 days to file the EIR. And so I just don't want the providers to follow that first step of going through the appeal process and then still not agreeing with the determination made by the MCO plans, and then coming to the state where we won't necessarily be able to rectify all issues within 60 days. So then it essentially, if we don't have it resolved, then it essentially removes the provider's ability to file an EIR.
Yeah, that makes sense. Well, we had at Theratree where I'm employed, we had a complaint that we tried to work out with one of the MCOs, and it never got resolved for 6 months. And so we filed a complaint with Medicaid and actually never heard back from them.
Dale, I would really like to see that example.
Okay.
If you had made outreach through submission of a provider complaint, whether it been via email through the provider MCO inquiry box or through the mail by sending it to the state, to the department, or submitting it by fax. We have had some issues with our fax line. So if it did potentially was submitted through the fax, it may have been missed. But Dale, I would love to see at least the example of how the submission was received. And
Sure.
then the issue has still not been addressed, and we can take actions to potentially address that concern.
I appreciate that. Yeah, it was faxed.
Okay.
And it's probably been 3 months ago.
Okay.
So I'll email that information directly to you. Okay.
Yes, absolutely. And this goes for any of the TAC members on the call as well. If you all have submitted via fax, please go ahead and outreach to the provider MCO inquiry box that was provided in the chat, because that is the team who facilitates provider complaints. And they'll be able to assist and look into it further if it needs to be resubmitted, so that way we can take action.
Just a clarification, on the 60 days, that applies to filing a complaint with the MCO in 60 days of the issue?
So it's following the MCO's appeals and disputes process. So if you receive an adverse benefit determination that you don't agree with, providers have 60 days to submit the appeals for that to the MCOs.
Okay.
MCOs have 30 days to make a determination from that submission.
Okay, thank you.
Thank you, Jeremy. The next thing on the old business is the therapy TAC proposed to the Kentucky Advisory Council for medical assistance to prohibit medical managed care organizations from applying multiple payment reductions, MPPRs, to occupational therapy, physical therapy, and speech therapy medical claims. The DMS response, the department reached out to the MCOs and was informed that none of the MCOs are utilizing MPPR for therapy claims at this time. In addition, if the TAC has a specific example that demonstrates an MCO is applying MPPR to medical claims, DMS will address the issue with that specific MCO. I don't know of any claims that MCOs have applied MPPR. Does anyone else on the TAC? No? So apparently, this is pretty much resolved by DMS that if an MCO does apply MPPR to OT, PT, or speech claims, then we should report that to DMS.
Yep.
And that's all.
Dale, this is Tam. I think this was in reference to the surprise move by WellCare trying to apply MPPR without proper notification.
Yes, that's
And-
what it was.
Yeah.
But they didn't do it that I know of.
Correct.
And this is Jeremy, just to confirm that expectation for the MCOs to not be utilizing that MPPR reduction was a communication that I sent. So if there is anything that you all are seeing from the TAC members differently, please don't hesitate to bring that directly to my attention. So that way I can quickly get that addressed.
Okay, thank you. So the next thing up is new business.
Dale, I think we need to go back to number 1.
Oh, that's what is Justin on here?
Yes, I apologize.
Oh, okay. How you doing, Justin?
Good, sir. How are you?
Good. The first question was an old business was a follow-up from the department about their studies on increasing OTs, PT and speech fee schedules. We just kind of want an update on that.
Yes, sir. So that study hasn't been fully completed yet. So we are doing some things in the meantime to try to give some assistance. You all know that we update our fee schedules every year in accordance with the Medicaid rates. I'm sorry, Medicare rates. And
Mhm.
so sometimes the fees increase, sometimes they decrease, and we make those changes accordingly. This year, we've increased the fees that have increased through the Medicare increased rates, and we have not decreased any of the rates. So we left that out this year. We anything that decreased, we left it the same as was on the 2023 fee schedule. So we were able to get that done for you guys. We also are in multiple talks with on several different key issues on exactly how we can work with rates and keeping those, comparable. So we have a lot of different projects going on other than just that main fee study that could potentially see some rate changes in the future. The last thing that we're doing, well, not the last thing, there's actually 2 separate projects that have started. One is a prior authorization review. I wanted to let you all know we were working on that. We actually hired a new employee, and this is going to be their first assignment, although we've started on it on our own. But their primary first assignment, and this is what their entire background is in research and policy, And so this is their first project will be reviewing prior authorizations for therapy. They'll be actually starting with therapy and durable medical equipment. But they'll be looking at every single prior authorization that we ask for therapy providers. And we're going to be going through that to see if we believe that's 100% necessary. If it's not, we're going to get rid of that prior authorization. In addition to that, and as a part of that, we're also reviewing the prior authorization process to try to make sure that that's easier for you all, for providers. We're looking at the way it's submitted, what information is actually required as far as to get authorization approved and payment, and to reduce the lack of informations that you all receive, the LOIs. We want to make sure that those are, if there's information that's not 100% necessary, that you all have a lot more time to get that in. And so it's not waiting on an LOI for something that's trivial. So a lot of different projects in that area that we're working on. And then the last thing that we've started is a project to review all of the different measurables for therapies. And part of that is looking at the fee schedule and looking at all the different limitations on the fee schedule to make sure that those are still appropriate, and see if there's any relief we can give providers as far as that area goes too. So we're attacking this several different ways while we're waiting on the fee schedule study results to kind of give you all some relief and to kind of help you all out. And I wanted you to know that, you know, every single day we're working on something, some project with therapies in mind and with you all as providers in mind.
Thank you, Jeremy. Is there a projected date where the 2024 fee schedule will be published?
We're hoping to get that out as soon as we can. I don't have an exact date right now, but it should be done fairly soon.
Okay.
Justin, with the rate studies, is there a projected date of when that's going to be completed? I know those can take several years.
Yeah.
Are we looking at another 2-year process here?
No, I think we'll be getting that done sometime. I mean, I don't have an exact date. I thought it would be done by now. I think they're looking at sometime in like a spring, like a March, April date. That's my thought. But I don't have an exact date. We haven't set that. They ran into, it's a complicated rate study. And so they've ran into issues, and we've had to go back and readjust what they're looking at, and, how it affected Kentucky in particular. A lot of states do therapies a lot of different ways. And so when we kind of collated all that information, it didn't exactly line up. So they had to kind of go back and relook at that. But I think that's kind of a ballpark.
Yeah. I think the main concern is, like, we're in this tight window. If it doesn't happen within this month, it might not happen for another 2 years based on the state's budget.
Right. And then, I mean, we weren't given any extra money in the budget for anything. So, that's always something to think about. But it's the rate study will dictate the rate change. I don't think it's something that is necessarily tied directly to this month or not. There's always ways that we can, make the changes we need to make.
I have a question about the claims. So since we don't have the fee schedule yet for 2024, will all of the claims with each MCO, do you know if they're required to automatically reprocess those, or we have to manually resend claims to get them
They'll automatically reprocess
for every single one?
Yep.
Okay. Sometimes we have issues with certain MCOs that don't follow
If you
that.
have any issues, again, let us know.
Thank you.
Dale, this is Pam, if I can talk again about that.
You okay?
So in past years, there are MCOs that refuse to retro reprocess, meaning they'll only go from, like, say the fee schedule was approved March 1, and they have 45 days to load, they'll only go then from whatever that date is, April 15th, or if that's 45 days. And they'll only go forward from that date. So they'll pay it all on last year's fee schedule until that date. So that's why we need clarification, just so we know what the rules are.
Sure. And we can send something out if you'd like for us to. I thought that was pretty well established, but if you have that issue come up, we can definitely handle that. We have an effective date that's listed on that fee schedule, and those fee schedules are tied to contracts, so that shouldn't be an issue, Pam.
So, okay, great. So I'm understanding you saying if the effective date is 1/1/24, then that is what is expected.
That is correct. Of course, I'm talking about traditional fee-for-service Medicaid, and the MCOs have to provide a minimum of what's on those fee schedules. Of course, each MCO will have its own contract with each provider. So some of that depends on what's exactly in that contract too.
Okay, Justin, there was you were out for old business item number 2, following up on the process of getting the retro PA from traditional Medicaid when a member applies for disability and is assigned from a MCO back to traditional Medicaid.
Yes, sir. I think we've got that process. We're working on getting it taken care of. It's kind of a complicated process, but we're working on that. If there's any, when you have those issues, if you bring those directly to us, we can get those handled quickly until we get our systems completely aligned. But I want you all to know that we're working on that system right now. It is it's just a system change that we're trying to get completed. But we're working on it. And in the meantime, if you have any of those, let us know.
Okay. Thank you, Justin. I just noticed that I skipped over item number 6 on old business. The physician's signature on the plan of care. DMS prior authorization reviewers continue to require the signature on the plan of care before processing PA requests. And that shouldn't be the case. Is there a way that DMS can communicate with the reviewers, PA reviewers, and get that information to them that the physician's signature is not required on that plan of care?
So I think we're going to have an individual from DMS reach out to you all and has started having some more frequent meetings, just kind of in between meetings to make sure that we kind of understand each scenario and situation. And I think this is one of the situations where we had gotten a request for some relief on this issue. And previously, the physician, I think it's 907-3005 maybe is the regulation that allows electronic signature. But prior to that, the requirement was that the physician had to sign. The same physician that ordered the therapy had to re-sign it in order for it to be valid. We opened that up after hearing back from you all and sent a letter out confirming that in August, that instead of having that physician, the same physician have to sign that, that any physician could sign it. It could also be signed by an APRN, a physician's assistant, and it could also be assigned by a registered nurse that was in that same physician's group with approval from the physician. So it opens it up to where, instead of having to have that same physician sign it, it can be signed by a myriad of clinicians that are working with that physician or in that physician's area.
Dale, can I speak? This is Pam.
Sure.
So Jeremy, I just wanted a minute to talk about this as I work I'm aware of people in other states who work with their state Medicaid on this exact issue. So one of the differences between CMS with Medicare rules is for everything, the language is all around rehabilitation. And rehabilitation is when someone's lost the skills they've had. And in Medicare, frequently, therapy for rehabilitation is a fall, an accident, an injury, an event like a stroke, something happening, maybe surgery. So the medical follow-up by a physician, a lot of times these patients are coming out of hospitalization, they're post-surgery. That's why the requirement for the signature on that plan of care is so important. But under the age of 18, when you're looking at Medicaid in the state of Kentucky, you're talking about largely habilitation. Most of what we're seeing is the child has never acquired the skill. It is habilitative services. And what we're seeing in our area is many pediatricians, like private groups of pediatricians, are no longer accepting Medicaid. In fact, there's hundreds and hundreds, I don't even know how many, lots of children that are going to be without primary care as they're making these changes. And that puts a lot of stress on the few large, mostly hospital groups that are accepting Medicaid or the outlying rural primary cares that are now going to have to absorb some of these patients. And even though the electronic signature is allowed, this is the process for a therapy group communicating with the pediatrician office. It's faxing because our EMR systems don't communicate with theirs. So we have to fax the document. Their office then has to print the document. Then the doctor has to sign it. Then they've got to scan it back. The problem necessarily isn't us getting it to them. We then have to babysit trying to get it back. And you're talking hundreds or even thousands of these things. The volume of therapy to a habilitative patient is much different. Medicare is largely a short term, it might be a 12-week period, where habilitation can go on much longer, 6 months, 12 months. Therefore, the frequency of these things coming at the physicians is much more frequent than a Medicare than a physician signing. So you've got not only the difference in the intensive medical patient versus the habilitative patient, but then you've got the volume and frequency. And I would recommend that our therapy TAC ask DMS to discuss this with the physician therapy TAC and particularly the pediatricians and gather some information of their feedback. Because I think as a state, we can decide, do we think a signed plan of care is necessary? Because us not getting them back from the physician means we have to stop that service. We have to interrupt that service. And until we can do that. And it's physically not possible for us to go to a physician office and stand there with 100 of these things to sign and get them to sign it and try to get it back. It's So,
Hi,
but yeah,
this is Dr. Terrio, and as a pediatrician, I'd just like to throw out
Fine.
that,
or it's signed, we've even had them sign,
I think
yeah.
Pam just went behind the mountain. She's
I-
traveling, actually, so
I think as a pediatrician, when the physician orders the therapy, they think that's it. They think the child is going to get it. They do not realize that the child is not going to get it until you sign that plan of care. And it is, and so I see this as a real, and I did not even know that until I started in this job with Medicaid. You know, they think they ordered it, they get this piece of paper that has the plan of care, they say, oh, great, they're getting it. There's no urgency in signing it. You know, it would be a big lift to educate all of the providers that you have to sign this and you have to keep signing them over and over to make sure the child keeps getting the therapy. And the pediatricians don't know that because they're never going to change it. There's no reason for the pediatrician to sign it, basically giving your approval for that plan of care, because they don't know what the plan of care, you know, they don't have the expertise to say, no, don't do that, do this. I mean, they're never going to say it unless they happen to be a therapist as well as a physician. And so it's really a rubber stamp. It's never going to be changed. It just needs to be signed. So I do think this is a big problem, and it's you know, interfering with kids getting their services. So it is something that we need to look into. I just wanted to agree with you, Pam.
Thank you for that.
Thank you, Dr.
Hopefully, can you hear me now, Dale?
yeah, you're not in the valley anymore.
Okay, great. Yeah, I am driving through mountains. So I would, you know, like to propose that, because the regulation, the words in the regulation is in collaboration with, currently, there's not anything for a provider if they're going to read through every regulation, everything in writing. There's nothing that states a signed plan of care is required. Nothing. And therefore, it's not required on the MCOs, not required in Medicaid. That's how it stands right now. So that's another point to this is, you know, our practice personally has MCOs telling us, denying claims, saying you don't have a signed plan of care, but it hasn't been a requirement. I mean, it's not written. So that needs to be cleared up. And then the decision of what do we do? What do we want in the state? Because in my conversations with pediatricians, they agree with that same idea that you all are the experts. We think when we send this physician order over, that's saying we want you to take over and help this child and meet the goals. And I believe the medical necessity comes through the prior auth, meaning any reviewers, even if they're randomly reviewing documentation at the prior auth, that's the time to catch, is this medically necessary or not? It's not through an administrative process of a signature, because, you know, there's not time in the day for that doctor to read all of those plans of cares. It just becomes a burden, and an administrative burden for sure.
Hey Pam, this is Jeremy. The denials that you're seeing from the MCOs, is it across the board or is it specific to certain?
No, yeah, it's certain MCOs and it's specific to reviewing our documentation, but us specifically being flagged on signed plan of care. When, to our knowledge, that's not a requirement. In writing, it's not anywhere written.
Well, I'm always happy to engage with our MCOs to clear the understanding and expectation of our interpretation of the regulation. And so Pam, if you want to send me an email, or any of the TAC members send me an email that you're seeing this behavior differently, I will happy to express that messaging to the MCO plans.
And
Okay, great.
Pam, I think it was a great idea you had. I think that this is something that, obviously we tried to address with the letter in August. Maybe it did not have the intended effect that we thought it might. So we can definitely meet. And I think your suggestion of getting together with the physicians TAC, having Dr. Terrio on, having some physicians from that TAC that are pediatricians, hearing your concerns, allow them to listen to what you all have to say, and then let them think about that and formulate a response. We want what's best for the members and in their healthcare. So I think we can come to, we can at least explore the possible change to this, and be open to that for sure. Once we get that feedback, I think that's an amazing idea. So I'll try to schedule that sometime. Hopefully we can get that scheduled this month, within the next couple of weeks, and then kind of see how that meeting goes, and then revisit that on our meetings in between TAC meetings. Does that sound like a good plan?
Does to me, yes.
I think so, Jeff. And one other, I was gonna make a comment too, is one thing too, even like CMS, they do require the sign care, but the only thing is they also have what they call a delayed certification. So they know that there's going to be a delay a lot of times. And for you to require it during the authorization process, when you can have a delay to get that, that's what's the holdup too. So even if they say, yes, you have to have a signed plan of care at one time or another, if you are allowing the delayed certification, that usually means you can go ahead and start therapy services until you get that. So I would like for them to look at that also.
Did the change in the letter, did the change in policy we made back in August, did that help at all? Or was that really of no help? Just curious.
I think what the problem is, Justin, is with traditional Medicaid, when they try to get the auth through the new portal, it's the same situation. They're requiring the signature. So I don't know. We always do get the signature before we in our practice, but so it makes it pretty hard for several practices to be able to do that are larger and that deal with physicians' offices that are much larger and busier than ours.
Justin and Jeremy, I'll add to what Pam is saying, that we are seeing that in the adult populations as well. I myself had an experience with a wound care patient where we had to delay care for up to a week because we were awaiting that denial, looking through the peer-to-peer to identify. Once we had a peer review conversation, it was because we were missing that signed plan of care. We then, despite having the conversation that was not a requirement, had to close that and resubmit an authorization. And so I would agree. I think a conversation between the physician TAC and the therapy TAC on that kind of administrative burden would be beneficial in the adult population along with the pediatric population, because it really is delaying services that these providers are sending to us to provide, and using our expertise in the matters.
Hi, this is Jennifer, APT. Can I add something on that?
Sure.
So I have an email and a letter from Commissioner Lee that DMS has agreed to not require signatures for the authorization process. I have even been sending those letters along with an authorization request to the portal team, and they are still, and it's not, I don't think it's every worker there, but we will still get an LOI saying, we don't care. Yes, I can see in writing that this isn't supposed to be required, but I'm going to go ahead and request that signed POC anyway. And I want to make something very clear because Linda touched on those delayed certs with CMS. CMS doesn't just allow for delayed certs, they allow for missing certs. They clearly outline black and white in CMS guidelines that the purpose of requiring POCs or having a delayed or missing COE, the intent is to not have the patient stop receiving services. That is not their intent. They make it very clear the patient is supposed to be allowed to continue to receive services, even if a POC is missing or delayed. And they do make allowances on how you can remain in compliances when both of those situations happen. But through the authorization process, we do not have that ability at all. We only have a 30-day retro window. We're getting authorizations after we're already providing services, trying to run on good faith that someday, somewhere, this physician's going to sign it and somebody's going to approve this, and it's just not happening. We're also being asked to change our plan of care dates to match the authorization start dates perfectly. And our authorization periods, particularly when 20 visits are free, don't match the POC dates. And we are being asked to revise those POCs and send them to the physicians, which is doubling up on all of the POCs that they have to sign, and they are getting very angry when they come back and go, I just signed this 2 weeks ago.
We are experiencing the same thing. This is Pam Marshall. And we are even, again, the MCOs are trying to hold accountable treatment plans missing established timeframes with start-stop dates and visits, even though we think we have the right information on there. So I think this whole requirement of signed plan of cares and the date ranges need to be clarified through this committee, through the TAC, so that the MCOs have that information and that it's not so difficult for the provider.
This is Hillary Armstrong with Foundation Hand and Physical Therapy in Richmond, and we're dealing with these exact same issues as well.
Well, hopefully we get this resolved soon. Justin?
This is Renee. I just want to remind everybody, we've been talking about this for way over 6 or
Years.
7 months. Yeah, years. So
Yeah,
at what point,
you're-
like,
yeah,
at what
you're
point are we
right.
going to get it?
We have been, and again, we went through that big change in August and thought that would be maybe, that would kind of do the trick. And obviously it has not. So I think this next step is to make another change, obviously. And we'll get some I know it's kind of been ongoing, but we'll get some resolution to it quickly. I'll try to get the meeting set up within a couple weeks, and we'll take we'll have a resolution from that meeting one way or another. And it sounds like there's a lot of little issues too in between there, but let's see if we can just attack the big issue first, and then we might not have to worry about any of those little ones.
All right, thank you, Justin. Let's be ready to move on to new business. The first item on new business is to a request to add the speech therapy to the speech therapy fee schedule, CPT code 92605, evaluation for prescription of non-speech generating augmentative and alternative communication device face-to-face with the patient for the first hour.
So
So we
we'll
get that-
research that and see if we can add that.
All right, thank you. The next item on new business is a provider reports when requesting a speech prior authorization through DMS portal. They are asking for proof that the patient is not receiving duplicate services at school. And Pam, if you're still on, could you address this? I know this has happened to you.
Yes, I am still on. So we've had this with, I can't quote right now who, but we have experienced this requirement where they're sending back proof that there's no duplication of service at school. And typically we are medical model outpatient. We don't get the school information, we don't have the IEP. Many times the parents have not signed a release for us sometimes to even get that. Normally we have to have that release signed before we can talk to the school or before the school will talk to us. So it's holding up the prior auth. They're saying they need it, it's required. And we're saying, well, because of FERPA, we don't have access to that information. And they really are two different services, educational versus medical model. So I'm just wondering if we can have a discussion about this issue and what's needed. Does the parent need to submit that? I don't understand what would be a good solution, but we can't be the middle person trying to obtain an IEP. Meanwhile, services are delayed waiting on the PA to prove that there's not duplication of service.
So Pam, this is the first time that I've ever heard of this, and we're checking with our systems people to see what's going on with that. That's not
Does
something.
anyone else on the call have that? Have they?
Yes,
experienced it?
APT over the last, I want to say 2 weeks, just started getting an influx of those requests as well. And it just kind of started out of the blue, and same issue. We don't necessarily know. And if we are aware that they are getting services at the school, like Pam said, we don't have those IEPs. Our therapists may make an effort to collaborate and find that information out, but my auth team does not know that and is just really not going to be able to provide this information.
Right. And it's also my understanding that the school IEPs, they no longer have separate therapy goals. Like there isn't standalone speech goals or standalone OT or standalone PT. And we are getting that request for OT and PT as well. So that's the other confusing part is I can't imagine we would have the same goals, or we shouldn't, because I don't think if we had similar goals to school, it would not meet medical necessity requirements. It would not meet interqual guidelines for Medicaid, for any Medicaid service. So it's a little confusing why this is a thing, why this is being brought up. I understand it's in the reg that we can't duplicate service, but I don't think it's our responsibility to prove that we're not.
Pam, this is Erica Jones. Thank you for bringing this to our attention. So a school is required to provide those services for that are in the IEP, regardless of whether or not they're reimbursed by Medicaid. So those authorizations should be two separate processes, the ones for the school and the ones outside in the community setting. So if you would allow us some time to look into what's been happening, I guess, the last few weeks, for why they're requiring proof. And we'll see if CMS can provide us some different models to make sure that this doesn't happen.
Okay, yeah, that would be great. And it made my mind wonder down the road that, oh, if this is a requirement, how would you decide if it was decided that if you submit an IEP and someone decided, oh, this is duplication of service, how do you determine who gets paid? That was the other thing I thought of is, oh no, like how would outpatient get paid or would school get paid? Who would get paid if they're billing Medicaid?
So I have a question, Erica, the new reviewers with this new portal, are they all within the state of Kentucky? Because I'm wondering if possibly they may live in a state where that is a requirement. And they just misunderstand the laws in Kentucky about this.
Yeah, I'm not sure about that, to be honest, because they're not state employees. They're contracted. So that's a good question. I know there has been a couple of prior authorization issues that have come up that are training related. I don't know if this is one of them or not. This is one we'll have to kind of check into and do some digging to see. I agree that it's not the provider's job to prove that it's not duplication of services. So let us dig into it a little bit and see what we can find out.
Yeah, and like Pam said, the IEP is written so different than like a plan of care for OT, PT, and speech in the medical model. The goals are blended into the teacher's goals on an IEP. So it's really be hard to tease out whether they're duplicating services anyway. So it'd be great if you guys can look into that and get some resolution on that.
Hi, this is Dr. Terrio again. I think it would be fine to assume that it is not a duplication of services because the educational model versus the medical model is so different. And many times children are getting IEP services, which might be once a week therapy in a group. And that's what they get for their physical therapy or speech therapy. And they obviously need more for medical reasons. And so once again, pediatricians will often, say you need, I know you're getting this in the school, but we're going to refer you to therapy because you need so much more. And the school you're going to meet those goals at the school and it's not even going to get near what you need for a medical reason. And I think people get mixed up when they hear that they're getting it at the school, but I do strongly feel that it's completely different and it's not a duplication. And if it can just be two separate approval things, I think that would be great. Just my opinion.
Yeah, at our practice, we actually have a checklist of that we can give parents, like for occupational therapy, for example, this would justify occupational therapy in the school. And this would justify occupational therapy in the outpatient setting. So, because a lot of times parents are confused that why am I getting, OT at school and at this clinic? And so it kind of, this explains the difference between the two models. Okay, I guess we can move on to the anybody. Oh, I think Linda, you have had a concern about getting PAs that you mentioned to me in an earlier email. You want to address that?
Yeah, I've talked to providers outside of our facility also, and they were saying that I think it was with traditional Medicaid, I said after the initial 20 visits, they were having to get reauthorizations. And when they went to go get the reauthorizations, they were having to do it every 30 days. And sometimes it was taking up to 2 weeks to get the authorization back. So by that time, it's time to start resubmitting again. And I didn't know if anybody could look into that process to see if we could speed it along, because we're either having to delay and stop because we don't have it back, or we're having to just continually redo it and redo it. It's just a very quick process. You're not even done with the 30 days before you're having to redo it again.
This is Hillary Armstrong again with Foundation Hand and Physical Therapy, and we're dealing with the same issue as well of that we can't see the patient until we get that authorization back, and by then, 2 weeks have gone by and interrupted care as well.
Yeah, thanks for bringing that to our attention. Well, let me look into it, see what we can do. And it's after the 20 visits are up, right?
Correct.
Correct.
Okay.
Okay, any other issues from TAC members or public that they'd like to address? If not, it doesn't look like we have any recommendations for the MAC. Is that correct, rest of the TAC members?
I think we have enough to keep Justin busy for a while, so. I think
Justin and Jeremy both.
yeah, and Jeremy too.
And we appreciate you guys.
I hope you don't have anything else to do, so take care of us.
No, it's good. And I really enjoy the fact that we've started to have these meetings in between TAC meetings too, because I think in the meetings we're going to have with the physicians, these are going to be great changes, I think, that we're looking at. So I think this has been very positive.
I agree.
Appreciate it. Yeah, thank you very much.
Yeah, we appreciate your time. I said, are there anything that you are going to be working on, you, Justin, or Jeremy, that needs to go to the MAC, or it's something that you can just handle?
No, I mean, I think at this point we need to kind of see where we are with these issues. I think the meetings with the physicians will have a resolution on that one from that. And I think having us looking at the new issue of trying to prove duplication of services in school settings, I think that's going to be something easy for us to look into and handle. And then this the PAs for after 20 visits every 30 days, and it's taking 2 weeks to get them. I think we can look into that pretty easy. So I don't see anything. And of course, adding codes to the fee schedules, I mean, that's commonplace. So I don't see anything right now on our end.
Okay, thank you. And I'm available anytime, Jeremy or Justin, if you need to meet with me. Okay, our next therapy TAC meeting is Tuesday, March 12th. And I'd like to take a vote to adjourn this meeting.
So moved, Dale.
Okay. We will see you in March. Thank you.
Thank you all.